Welcome to We Can Be Zeros. We have a Facebook Live event today. We had a technical glitch there a moment ago, so I do apologize. So today I'm delighted to be joined by Dr. Marie Casey. Dr. Marie Casey is an expert in public health. And has been on the front lines leading the battle in terms of the COVID-19 pandemic. Thank you very much, Dr. Marie Casey, for joining us today with We Can Be Zero. You're very welcome, and I'm especially delighted to have the opportunity to, I suppose, have a chat with you, have a conversation with you. I suppose really to I suppose learn a bit more about public health itself and that area, that discipline in our health service. Because if I'm honest, you know, I suppose prior to the COVID-19 pandemic, I would have had a perception of what public health is, but not a proper understanding of that area, of that discipline, and the role that it plays in all our lives in society. And so I'm delighted to have this opportunity to have a chat with you today. And I suppose initially just for you to talk a little bit about public health itself, just the broader discipline, not so much maybe about public health in Ireland, but what is it? What is it that goes on around us within our daily lives? What do public health doctors do? And we can maybe talk about the COVID-19 pandemic that maybe brought public health into sharp focus in all our lives. But what was going on in public health prior to the pandemic? And tell us a little bit about public health and why it's important.
Hi, thanks for having me in to talk today. I suppose public health is actually a hugely broad area. Almost anything has a public health impact or relevance. There's a lovely definition of public health out there, which kind of exemplifies that. And it's about preventing disease. It's the science and art of preventing disease, prolonging life, and promoting, protecting, improving health through the organized efforts of society. So that's a pretty broad, broad brush. And you can see that there's an awful lot of things that come into public health, like education, employment, public places, and also, I suppose, in infectious diseases now at the moment during this pandemic. So I suppose public health, the discipline, the medical discipline, really began probably back in Victorian times when there was high rates of infectious diseases and there was issues of water and sanitation and quality, water quality at that time. And an awful lot of countries developed a role called the medical officer for health role, which we still have today, which all countries still have. And it's a role that's required by law in each area to actually, identify sources of infection, to control them, to inform yourself as to the causes of diseases in the area as well, and to look at the patterns of diseases. Because I think there was this recognition that there needed to be obviously doctors who look after patients on an individual level, but also having doctors who look at the whole population together and actually address things that might have a wider impact and might affect larger numbers of people. So this medical officer for health legislation still stands today in many countries, including our own, and we have that role within our own population. And interestingly enough, it's a role that's required by international law as well. So according to the international health regulations, which are basically the legislation around all the countries working together to notify each other of infectious diseases. I suppose this would have been very important during the pandemic. This would be the basis on which we'd share information between countries during the pandemic, and to highlight the issues in our countries to each country to one another. We require doctors, medical officers for health to do that role, and that's what we've been doing. So I suppose we work. There's this role, I suppose, as a public health doctor has changed a lot over the years, though. So, and I think we're working more broadly on wider issues than we used to do. So it started very much from a time when infectious diseases and water sanitation were the main focus. And we still do that every day, but we do other things as well.
Okay. So I suppose when we think then about, I suppose, just thinking about last January 2020 and February 2020, what would have been, like, I be very familiar with, I get up, if I get sick or if I have a complaint at me, I go to my GP. I might go and sit down, then I might get a prescription, or I might have to be referred to a consultant. I get an x-ray. I might get if I go to get an x-ray, is it a radiologist will x-ray me. I might encounter the cardiologist. But in my day-to-day life, I may not ever sit in front of a public health doctor and sit down and have a conversation. So this is why I'm so happy to be able to do this today. So like, pre-pandemic, can you give me an example of something that a public health doctor might do, that I might know about and a lot of people might know about, but that's very important and that indirectly impacts on my health and my life?
Yeah, that's actually easy enough. And I think I was thinking about this question this morning, and I was thinking, actually, an awful lot of the time, the things we do when statements are released by the HSE, it just kind of says the HSE has decided to do X, Y, and Z, and actually, it's our public health function has made those decisions. So I suppose on a practical level, going back to infectious diseases, which we all do, we would have been organising, like if there was an outbreak of VTEC, which is a gastrointestinal infection in a creche or in a childcare setting, we would have been managing that. If there was a flu in an outbreak inside a nursing home, we would have been giving advice on what to do and what medications to use to prevent infection. We would have also been giving advice on immunizations as well. We'd also we're also responsible for water quality and other issues like that. So if there was a contamination incident, or if your water was unsafe your water supply was unsafe for human consumption, we would be actually asked to give advice on what to do in relation to that. So we would work with our environmental health colleagues very closely to decide whether or not to, decide that it's a boil water notice for the area, or that we need to actually tanker water in, or things like that. So those are the kinds of things we would have done regularly. Another thing too, just even practically now at the moment, if there's a beach closure around water quality, we're asked about that too. So we give advice on that if we think that it could lead to an outbreak or could have impacts on human health. So we would always have done that kind of work. We would have also worked more broadly as well. So the main areas of public health, we've got categories for them now, but one of them would be health improvement, which is around improving risk factors for disease. So like we would have designed things like smoking cessation programs and things like that. We'd also be looking at, we're getting more involved in the screening programs, which is really positive. So we've had recently got a public health lead appointed into screening, which is excellent as well. So we would be trained actually to run screening programs. That would be part of our role. Another part of our role is around health services improvement, and it's around improving the quality of services, and also maybe assessing what's a good value for money in relation to health services as well. So I worked in England for years, and I would have done quite a bit of that. So if there was a new medication coming on, I would be part of the process and looking at the research to see if that was something that was worth using in the health service. And then obviously health protection is around the infectious diseases and environmental issues. And underpinning it all is health intelligence, which is around data and research and evidence. And I think that's really important, because just going back to your example, you're talking about how you go into a radiologist, or you have a broken arm or something like that, and you go in and you get an x-ray. The tools we use are very different in public health. So the tools we use is data and research. So we look at surveillance data and other types of data, which shows how much disease there is and who has it and what the pattern is telling us. And then we also use things like research as well to say, well, what's the best thing to do in this situation? So the evidence that's out there as well. So it's a very different, I suppose the process is similar. We're diagnosing using loads of data, and then we're trying to advise population-based measures to treat whatever issue it is. So still kind of doctors, but on a much bigger level.
Okay. So I suppose what I would take away from that would be, in terms of, I suppose, the type of research and the data that you would be analysing, that would inform maybe strategic decisions that would be taken, with a view to, I suppose, the type of services that need to be offered in certain areas, maybe, and the type of approaches that would need to be taken in certain areas, depending on epidemiological information. Would that be a...
That's it in a nutshell. You said it better than I did.
Okay.
But that's exactly it. We use that, and we look at what's going on in other countries. Like we always have a very we stand back and look at the bigger picture always. So it's a job for somebody who likes looking at the bigger picture of things and standing back and thinking, hey, where should we go with this, or what should we do? It's a really interesting job, because I absolutely adore it, because it involves so many different elements in evidence. Like you're reading sociology, psychology, you're learning about infectious disease data, you're using your own experience as a doctor as well as a clinician. So I worked in hospitals, I worked in primary care, so I know about the reality of that too, and I use that kind of experience as well in my job every day. So yeah, it's a really great job, and really interesting as well.
So I suppose really it's everything that would happen in our hospitals and further afield. Really, there's so much activity taking place that's unseen, that goes on around us. So essentially, what I would say is there's a lot going on around us, and our environment as well. It's all tied into what public health does. But I suppose, can I ask you a little bit? Can you talk a little bit about March 2020? Because on a personal level, I don't mind admitting this. On a personal level, I've seen reports in the media of outbreaks of MERS, outbreaks of SARS. I can remember the bird flu and swine flu and various different. You hear about Ebola. You hear about all these things in the news, and I suppose, thankfully, in many cases, like Ireland, kind of escaped a lot of that. While we were aware of it in the news and stuff, I think a lot of us would have said, "Oh, thank God, we're not in that situation in Ireland." But March kind of 2020 kind of changed everything for people in Ireland, because what we saw, this virus originating in China, and but it could have originated anywhere, but it originated in China. And I actually don't like saying, I don't like labeling, putting a name on it, came out of China, or it came out of here, or it came out of there, because I think that does a disservice to the people who live there. But because it could have came from anywhere, but when so it originated in China, and I, on a personal level, my first thoughts were, this isn't going to come to Ireland. Because of my previous lived experiences of seeing reports of other viruses in the news that didn't come to Ireland anyway. I can remember the foot and mouth crisis, the foot and mouth disease and things like that. But again, I that was very, very different. I didn't feel personally under threat from the foot and mouth, but then this started becoming, in March and April, this started getting a bit scary, for people in Ireland. So can you tell me a little bit about how this kind of, because this is on a personal level, like this has changed me and my approach and my thinking, but how did it impact public health in Ireland, and what was it like at that time? Tell me a little bit about that.
I think it's interesting that what you said there about SARS and MERS and Ebola and all those things, because when all those things happened, we were spooling up, our activities and connecting more with those countries that were involved, and we were taking every precaution and action. At the time, I was working here when Ebola became an issue in Ireland, and I was engaging with the companies who were had interactions with the countries that had Ebola infections, and looking at how we might reduce the risk to importing a case in here. So we're always there, kind of working away in the background, and obviously the better we do, the less happens here. So our greatest success when nothing happens whatsoever. And I think this was, I suppose it's interesting to think about the start of it, because we hear about what's happening in all countries in the world as regards outbreaks all the time. There is an awful lot of information coming to us all the time underneath those international health regulations I mentioned earlier on. So we always hear, like I hear about an outbreak of measles in South America, or I hear, those things, that information comes in all the time. And then this thing came in, and I suppose at the start, I think part of me was thinking, well, you will see what it is, because sometimes you get this notification and it turns out to be something that we haven't seen before, but it mightn't turn out to have much potential for spread, and it goes away again. And we see this regularly enough, like we monitor this very closely internationally and locally. But then I think we started realizing fairly quickly that this was going to be an issue, and that the spread was going to be an issue, because it looked like a virus that could spread quite easily. I suppose what I was thinking at the time was like, oh gosh, this is a bad time for us in Ireland to get this, because we're not quite ready. We were just about to start reorganizing, because there was a long-standing recognition in Ireland that we hadn't, public health was kind of underfunded and wasn't kind of structured quite well enough for what it needs to do nowadays. And we were starting a reform process to do something about that, which we were all very excited about. And we were also just about to buy a system to help manage, an IT system to help manage outbreaks. So we were literally at the cusp of sorting all these things out, and then this happened. I was on call the first weekend that the first people who were being tested for COVID were started coming in. So I was on the phones, and at the time, like this, I mean, we've come so far, but at the very start, every test for COVID had to be approved by someone like me in each area. So I would get, we would all get phone calls day and night from ambulance service saying, we're going out to swab XYZ, do you approve this swab? And then this would happen. So I started off with that, and I had started off with people from China who had respiratory symptoms, and we were having to organize their testing. And I remember at the time, I was saying to one of my colleagues, I said to her, well, what's this going to be like? How long do you think we'll be contact tracing for, And we were discussing this at length, really. And what was interesting is, and maybe this is something to say as well, is that at the start of every pandemic, the mortality rate looks really high. And that's because the people who are most likely to be tested are the ones who are inside, are very seriously unwell. So just to recap back to 2009, I remember talking to somebody at the time with the flu pandemic, and we were looking at a 10% mortality rate at the start from Mexico. And we thought, well, God, I hope it's not that big. But we also knew at the same time, okay, they're testing very few people, and they're testing the people who are in ICU, so it's more likely to pick up people who are seriously unwell. So the mortality rates at the start of every pandemic are always a bit of a mixed bag. We don't really know what we're facing for a little while until our testing capabilities go right up, And I remember talking to my colleague who'd been through the flu pandemic here in Ireland, and she said, well, actually in Ireland, we stopped contact tracing after the 100 case of flu back in 2009. So we've gone far beyond that, into the tens of thousands now. She said, we contact traced for 6 weeks. So at a fairly intensive rate back in 2009. And then it was just, the vaccination came in rather quickly, and it was allowed pass through the population. The mortality rate was very low. So, but this was different, and we had to sustain a far higher level of public health activity and interaction and intervention, for up to now. Today, we're still doing it today, exactly what we were doing last year, albeit in different ways,
So it's, I suppose it sounds like it was a bit of an unknown quantity then.
Always,
we just didn't know what we were dealing with, but I suppose I remember just to bring you back a little bit, where you said I think you were in the middle of a reorganization or a reimagining of what public health will look like, maybe even a reform, if you want to call it that, and this kind of hit. I suppose it sounds like maybe maybe we weren't prepared to have to be even to be contact tracing and to go at this over a prolonged and a sustained period of time for as long as we have had to do it. Would that be a fair comment to make, or would that be a fair observation?
I think I think partially, Craig, sorry. I think it's partially, yeah, you've got it there in some respect. We weren't ready, I think, but not a lot of countries were. You know, I was reading a report recently, an international report on our pandemic readiness that was published in 2017. It was basically saying every country is a disaster and we all need to sort out and invest in public health, and a pandemic is going to happen any day now, and it has. Public health is a hard sell, health investment wise. It's far easier to get funding for a hospital or an MRI machine or something like that than it is a public health team, you know. So in Ireland, we would have started off with a low level of public health doctors, and we didn't have teams of public health trained professionals working with those public health doctors. So that was something we recognized, and we were trying to get into the reform, and we've been working on for quite a while before the pandemic. So we were not ready, and we did not have enough of my type of person or people who worked with me who were trained in public health. Now, in fairness, every country has had to increase their contact tracing ability. So, like, these contact tracing centres were set up in Ireland to actually do that for us at high volume, because it was very evident that we did all the contact tracing in the early days, but it was very evident that at higher numbers we weren't going to be able to sustain that. So the process had to kind of split, so that basic contact tracing could be done by people who were less trained, and then we could focus more on the areas that needed more skills. So someone like me would focus more on outbreaks or complex risk assessments that might involve settings like restaurants or workplaces or nursing homes or things like that, you know. So yeah, it's a yes and a no to that.
Yeah, okay. And I suppose like 14 or 15 months down the line, I suppose where are we now, Marie, in terms of you know, because there's been a lot of firefighting going on, but where are we now in terms of are we in a better position? And I say that very aware and I'm very conscious of I suppose of what's going on in the country, what's going on regionally, even in around the Limerick area. There seems to be, you know, there is cause for concern at the moment. I'm very aware of that. But in terms of the context of public health, are we learning enough on the job, if you want to call it that, and are we in a better position now than we were 14 months ago, do you think?
I think, yeah, we are actually, you know. So I think the first thing is that we have gotten more. We've started recruitment processes for teams, and we've gotten some of those staff in place now. So for the first time ever, we have a health protection nurse service within public health, which is amazing. And it's something I had when I worked in England, and the nurses are absolutely brilliant, and so are ours. And it means that we can train these up to be professionals in this area. And it just gives us a broader skill set within the departments as well. We're going to have some more surveillance scientists, which is great for managing all the data, because there's so much of it now, and reporting all those outbreaks and assembling all the chains of infection in the data reporting. I'm also very hopeful that we'll get into a phase where we start looking at other skill sets that we need within public health, like public health researcher skills. You know, I think we also, you know, I'd like to see more people who are kind of on the data science side coming in as well, because I think it's really important that we communicate what's going on in the health data as well. So things are improving. There was also some movement on the public health consultant contract for us as well, which is going to help us with recruitment and retention of the people we have within the service, because we've never been able to successfully recruit people from abroad before, and that will give us a bit of a chance to do that. And there's going to be an increase in public health specialists in the country, so we're going up by about, I think, less than a third, but that's still an improvement on where we are. So things are improving. Now, IT wise, we still have a bit of work to do, or to a bit of time to go on that. We're hoping to get an infectious disease outbreak system which we should have had, which would have made a huge difference in the pandemic. We're hoping to get that in place in the next year or so as well. So it just takes a bit of time to build it because we have to customize a system for ourselves, but those things are improving as well. So slowly but surely we're learning. And I think it's really important as well that we take the opportunity to learn as well, because pandemics are increasing in frequency. You know we've had more pandemics in this century than we did in all of the last century totally. So they are going to increase in frequency, and we're going to get them more often, and infectious diseases which have pandemic potential will arise more frequently. And that's because of environmental issues. So it's about increases in population and their proximity to wild animals. Once you have humans and animals mixing together, you have opportunities for viruses to start jumping species, and that's what we have in this situation. So that's something that we have to bear in mind, and I think globally that's recognized as well. So globally, I think everybody can acknowledge that they were not prepared and they'd underfunded public health, and they hadn't put good systems in place, for public health across the world. And even our systems for notifying each other about what's going on in each other's countries are a bit too slow, and we need to improve those as well. So once we all jump into IT, that will help us an awful lot, which I think you could relate to.
I could maybe a little bit. I want to see if I can just, I suppose I want to play you a little clip of just some audio for a second. It'll be audio for anyone who listens back to this maybe later on, but it'll be a video for anyone who watches with audio. I just want to get your reaction to this, and just to discuss this for a second. And I just want to, before I play the clip, I want to just premise it by saying, we understand here at Week in Zero, we understand the challenges that everyone is facing right throughout our health service, everyone in society, businesses, right up to government, and we know that everybody is doing the best they can. But so I want to play this little bit of a clip, and I just wanted to gauge your reaction and just have a little bit of a discussion on it. Now, hopefully it'll work. I tried doing this before and it didn't quite work out for me, but let's see if it works this time. Just give me 2 seconds there. Okay, now, okay. Okay, that should, I don't know if that's coming through there. I don't know, could you hear that?
Couldn't hear, but I can read the subtitles. So
okay. Okay, okay. Anyway, look, that was a short video of An Taoiseach Micheál Martin and talking about the B117 variant. And I think it was a UK variant. And I suppose the context of it was this was at the start of our reopening. And that was probably the first 10-20 seconds of the speech, which I knew and a lot of people know was so concerning, that we the virus has changed. It's different. It's not the same. We're not dealing with the same virus. Plus now we have a new virus, which is called, I think it's been recently relabeled Delta variant, which I would welcome, because again, I don't like calling things UK, Indian.
But you're actually right to say that, because the Spanish flu, which is known as the Spanish flu, the 1918 one, didn't originate in Spain at all. That was
I think it originated in Kansas, did it not?
Yes.
in the United States. That's right.
Yeah, so we should
Yeah.
call it the American flu. But we
Yeah,
don't.
exactly.
So
So
you're right.
I don't think
Yeah.
that's helpful to call it to kind of almost give it a nationality, because
It doesn't have
viruses don't have nationalities. They don't carry passports. But I suppose that speech though might be on Taoiseach Micheál Martin. He goes on in that speech to talk about how dangerous this virus is, and if we give it the space it needs, the consequences are terrible. And I just wonder, and I'm still wondering at the time, are we not giving the virus, especially this Delta virus, are you not concerned about the space that we're now giving it? And we're about to, we're embarking on we're easing restrictions. And we see what's going on in the UK. I mean, as a public health doctor, how concerned are you about where we may be going here? Because I suppose I'm aware that, look, I'm lucky. I've actually had my 2 doses of vaccination, but there are many people who are just not vaccinated at all. There are some people, and when I say vaccinated, I talk about 2 doses. So for me, you're not a dose of vaccination. If you're getting certain types of vaccines, it's 1 shot. In certain types of vaccines, it's 2 shots. But for me, fully vaccinated is depending on the vaccine. It's for many people, it'll be 2 doses. You know, especially very clinically vulnerable people. So I'm very concerned. Because I know lots of people who are not vaccinated yet. And I know there are many more people that I don't know who are not vaccinated at all, and they may be vulnerable. And I'm just concerned about where we're going over the summer and where we could end up. It seems like there's a race taking place in terms of getting vaccines into arms now, and this new variant, this Delta variant, which
it is a race. Yeah, it is a race. You know, I think it's about being balanced. You know, in relation to this, I think the important thing to say is that the vaccines are still covering the variants well, and in the Delta variant, it's even more important again to be fully vaccinated as opposed to just having the 1 dose of a 2-dose vaccine. It's not enough. Really, you need to have the 2, but it's still they're still effective and things like that. The wave will look, if or when we get another wave of infection, or if we get increases in this particular variant, it would look different to what we've had before, because an awful lot of our older people are fully vaccinated now and protected, and so we might not see, or unlikely to see, the mortality rates we've seen before. Thank God, because that, you know, January, February was extremely difficult in that respect. Personally, I feel like on an individual level, I think people need to just keep doing the simple things well, and I think also know what's going on in your area, so and be aware to that. So not to look at the rules around restrictions as I can do all that, it doesn't matter what's happening around me. Actually just say, okay, I'm going to get all my simple things right: my mask wearing, my distancing, ventilation in workplaces and other public buildings. And then, you know, also, you know, still present for testing, go in for testing if you've got symptoms, do all those simple things. But then the additional thing is be aware what's going on in your community. If it looks like there's a blip of infections in your community, take more precautions. Don't hold that gathering and things like that, even though you might be permitted to, because that's the kind of thing that gets infections going again. I will say as well, the numbers, what you said earlier on there about the virus being different, the numbers are different to last year in a way. So at the same level of cases last year, we would have had way more spread. Whereas we find now there's so much transmission within clusters that we can have a relatively small number of clusters, but they can have really high levels of infection within them. And that's, so in some ways, from a public health point of view, that's actually kind of less concerning, because what's more worrying for me is if I see, for example, 30 cases spread all over the place and no connection between them, because I'm thinking there's more infection out there that I know nothing about, and it's everywhere, rather than I've got 30 cases and they're all in the same, you know, in the same family and they were at a party together. Then I think, okay, I can control that. I can cut the chains of infection from there and contact trace out from there, and we can sort that out. So there is a difference in how the numbers are different now. They mean something different than they did last year. And I was looking at some statistics recently from last year and from this year as well, and the infection rate for close contacts last year was around 10%. So close contacts of cases was about 10%. Now it's up near 30. So we have this way more intensive spread. And I suppose that's what concerns me a little bit, is that we've really got to minimize those mass spreading events, because the secondary attack rate, the attack rate is so high now, that you can get a fairly huge.
So you're talking about,
quickly.
you're talking about there, when you say the secondary attack rate is high, is this figure of 50% more transmissible? Is this what we're saying?
Yeah. And that's translating into the 30% close contact positivity rate that we're getting. So that's what we're seeing in our own stats at the moment, our own numbers, because there's probably a mixture of variants going on. So that's what we're seeing for everything, you know.
And I suppose the concern, what I think about, what I wonder in my head is, like, I remember last year, and I can remember, I don't know for all the good it did, but I thought it was a nice gesture. We were all out clapping. We were all out clapping for our public health teams. I got myself, my wife, my kids, we went out to our door. We made a lot of noise. You know, I think it was nice it was good in terms of, because my son was asking me about it afterwards. Why did we do that? And I was able to explain a little bit to him, you know, which I think is important, you know. But what I'm wondering is while, like, thankfully and hopefully we won't have, I don't want to see anyone dying, but is there not a risk that we could still have a lot of hospitalizations? Because young people, because this virus has been sold, and it's kind of, for me, I think it's dangerous throughout the wider media. Oh, you know, if you're young, you're grand. But that's not the case. I don't think that's the case, because
it's a lower risk. It's not a no risk situation, you know. I have seen young people, you know, hospitalized. I've seen pregnant young women hospitalized. You know, that happens. So you're absolutely right. You know, I think perhaps I was maybe clumsily saying earlier on is that the mortality rate will decrease. It will look different, but there's always a risk as well when we have high rates of hospitalizations, that it kind of displaces the other hospital activity, the other healthcare activity that we have. And what I've always found very interesting is people talk very much about, oh, you know, we've all stayed at home now to protect the HSE or protect the NHS. And it's actually not, and I always thought that is kind of a funny way of saying it, because I think some people think it's so doctors and nurses can have more relaxing times and have more time for hobnobs or whatever. But actually, it's actually to allow them to do their other work, because you know, our current workloads and the current workloads of my colleagues in the hospital, in primary care, that was at the top of it. They were over their capacity before the pandemic. You know, treating the heart attacks, treating the cancers, treating the strokes, doing all the routine stuff that needs to happen. That's really important. And the thing is, you can't have uncontrolled spread, because those patients will turn up to hospital and take beds of people who need to have those other treatments. So you can't have both, you know. So yeah, no, I do agree with you. And I think that's kind of why I want it to be us to ease extremely gently and to be very careful over the coming weeks. Because every week that passes, another cohort of people start to develop immunity. And I think we're down to that at this stage. We're down to weeks making a huge difference at this stage, because I feel even personally, if we could get down even to the 30-year-olds having their full immunity, you know, it would be a huge thing. And then obviously into the 20s and then younger again. So, you know, it's, I think, taking it really easy over the next while and very carefully, especially if you or your family are not vaccinated yet or haven't had any doses. You know, this is not the time to throw caution to the wind. You know, it's, you know, in a very short space of time, you will have vaccines, and I think everyone should have the opportunity to have their vaccine and have their chance at immunity as well. You know, before we get we get huge numbers of cases. So that's it really, you know, until they get, so yeah.
Okay. Okay. And again, because just to, I suppose, finish off that point, I mean,
Yeah.
we know that we hear like, oh, the vulnerable have been vaccinated now. So if there are hospitalizations, oh, it'll be very low numbers, but or a low percentage of the population will be, may get infected, and they're not going to get too sick anyway. But even a low percentage of a
Of a big
large number
number.
is
There's
a
a lot
lot
of people.
of people. And like what you're saying is, if there's a lot of people being hospitalized for COVID, that's going to put that ties up resources
It ties up resources.
in terms of dealing with that. And we want to avoid that, because like what you said, there are other people like who need the cardiologist, or there are other people who need the other services. And what we don't want, and this is why it's almost like bringing us back to what a lot of people maybe might want to hear it now, but we are actually in this together a little bit. There has to be that approach that still has to be there, I feel, because there are people who have maybe missed out on access to certain services over the past 14, 15 months because there was such a drain on resources, and that was just what happened. But that's why we need to be really, really cautious here. And like, for me personally, I think we should be a little bit more conservative over the next few weeks until we get more vaccines into arms and get more people protected, because this Delta variant, I think
Yeah.
could be, we see what's going on in the UK. There are surges in local areas in the UK. We don't really want to be seeing that in Ireland,
Yeah, and I think when we look at restriction levels, I think we shouldn't look at the restriction levels as the bare minimum of what we should be doing. I think we have to apply, some judgment ourselves to it and say, okay, well, for example, in my area at the moment, quite a large number of cases. I'd be thinking I'm taking more precautions because that's the logical thing to do. If there's an issue in your area, that's what you need to do. You need to think about being aware of what's happening in your area as well, but also be also aware that things may be happening and you're not aware yet. By the time cases start coming into an area, a lot of transmission may have already occurred, and you can get a big blossoming of cases very quickly. So I think you're right. Like, I would like to see a little bit of caution over the next 6 weeks or so. That would give us a bit more time to vaccinate some more people. Every week matters right now, and I think that's really important. But also, it's really important to know that there's, like, the end is in sight. Things are going to improve a lot over the next while. They're improving already. Like, when I was working in January, I would come into work on a day, and there would be half a dozen deaths reported overnight. That was just, it was crushing for me, because at the time I was thinking, these people were so close to being vaccinated. What a shame! Like, what an awful thing to have happened. And some of them had even just, they'd received a vaccine, but they weren't immune yet, and then they contracted COVID. So I don't want to see that again. What I want to see is a bit more time until everyone's had a chance to have their vaccine and to be protected, particularly the adults, because they're more likely to have health issues from it. And then we'll be in a really good place as a country then. I think everyone's done amazingly well, though. Like, the whole year has been so wearing and exhausting, and like the chronic levels of stress for everybody has been unbelievable. But I don't know, like, I still think people are kind of amazing, though, because I talk to cases regularly. I was talking to people over the weekend, and they're so good. They take your call, they tell you who their close contacts are, they've gone for their tests, they've tried to do all the right things. So, like, we have to bear that in mind too. The vast majority of people are really trying to pull in behind us here, and we just need to keep doing the right things. I think it's going to be a bit more complex over the next while, because of people having more complicated social lives. So just from our work is going to change a little bit over the coming weeks. So when we had cases a month or two ago, like, you close contacts wise, they would have maybe their family, maybe a friend or two. But last year when we opened up again, like, people had very exciting social lives, and numbers of places they'd been over a weekend. I remember contact tracing somebody who had over 70 something close contacts, because the person had been out 3 nights in a row at different restaurants, and they were not a young person. Okay, before anyone says I'm judging a young person, they were older. So yeah, like that's going to be a challenge for us in the coming weeks, but we'll get there.
Okay, Marie, I have one last question to finish up, because you've been really generous with your time, and I know
No
how
problem.
busy you guys are, and I know how tough the last year has been. So just to go back, so post pandemic, I want to think of a little bit about the future. When we come out of this, as a public health doctor, what I want you to do is I want you to imagine I'm the person in charge of the resources. I've got the keys. I've got the keys to the kingdom. What's on your wish list? Give me three. Give me three things that's on your wish list for
only
public
three.
health.
Only three.
Or
well, I think what I want to talk about is I think the next phase for our public health response will be public health recovery from the pandemic as well. So I'd like to see us look at a kind of a mental health and well-being strategy for improvement after the last year, and also incorporating social and cultural recovery as well. I think that's a really important thing, because we've spent a year apart from each other, over a year apart from each other, and we need to ease back into being together again. And I think I'd like to see something on that. I'd like our health protection function to get strengthened up as well. We really need to be using huge amounts we need proper technology, and we need to cover all the risks as well. We need to cover climate change. We need to cover environmental threats as well, water quality, air quality. All those issues are really important in public health. And I'd like to see, maybe this is a global wish, but we need to actually improve our intelligence and our data sharing across different countries. It would surprise you and probably shock you to know the levels of technology that are in each country for public health. So we're bad, but we were bad, and we will be getting better, but it's not unusual. There's an awful lot of countries who don't have technology or decent technology, or even a national level technology. So we need to improve that as well. It's really interesting. I was looking at the Europol, and they have amazing technology for sharing information about criminals and sharing information, and it's so real time and it's so easy to see what's happening, whereas we're still in public health sending each other an email over to another country to say, hey, we've got this going on. We lack that infrastructure to actually kind of create early warning systems. So that's what I would love to see, that strengthening. And I think that strengthening should actually incorporate lots of different things. So we should be looking at infectious diseases, but we should be looking at other issues as well, because they're all related. And who knows what the next threat will involve. What we've learned from this one is we can get a surprise. Yeah. And I suppose the other thing, and I have another wish.
But no, it's really interesting you said that. And I suppose when you talk about even about early warning systems, there are lots of professions and other disciplines that, for example, we have early warning systems in countries for earthquakes and storms and things like that. So that technology can be manipulated and used. So we have it. It's here. It's around us. Essentially, for me, what I see is what there needs to be more collaboration.
Yeah, and I think one of the issues is that technology in public health hasn't been traditionally invested in, anywhere. In most countries, I would say very few countries would have had fantastic capabilities starting out. And that's terrible. We need to actually have a global level of technology. And I think one of the issues is that there aren't a lot of vendors or companies creating public health technology at a price that all countries can access or get involved in. And I think it's because it's not a huge market. You buy a public health system, and each country only needs one. It doesn't need tons and tons and tons of different types. So it's very much something that is a global priority. I think it has to be a global priority. And I think the WHO recently announced that they're going to set up a centre looking at this in Germany. And I think that is absolutely essential, because an awful lot of countries had a huge problem before they even realized what was going on. I think in Italy it took them a while to recognize what was happening in their local area before it happened. And that's because pandemics sneak in. They come in with symptoms like any other illness that we have. Like the first cases of COVID, did anyone think that they had something other than a cold? No, probably not. So it's only when people start, clinicians and people start noticing differences and saying, hey, I've actually got a couple of people who are very unwell in ICU at the moment. It's a real, the pneumonia looks a bit different. That's when you start connecting it up. And that's part of it as well. It's actually having that sensitivity that you can actually start recognizing, oh, we've got a blip of hospital admissions with a certain type of symptom pattern. Is there something going on here that we don't understand? And I think that's the thing. We need to have that level of sensitivity all over the world. And we need to support all countries to do that, you know. And it's also important to recognize that not all the countries where pandemics are more likely to happen because they've huge numbers, huge populations, probably are less likely to have the funding or money for infrastructure. So it really is a global good, and it's something that we need to happen globally. And I think it's going to be an exciting time for data science and data analysts in this area, because there's so many pieces of information that could be used, you know, to monitor these things, you know. So yeah, it's good.
Okay. Look, on that note, we'll wrap it up. Marie, thank you so much for joining us today on your day off. You know, after the year we've had and everything, I'm so grateful for the opportunity to have a chat with you. It's been really, really interesting. Yeah, so have a good day. Enjoy the rest of your day. Thanks to everyone for joining us as well. The video will be live across all our social platforms in the next few minutes. Again, thank you to Dr. Marie Casey for joining us today. Have a great bank holiday weekend, everybody. Stay safe, wash your hands, wear your mask where appropriate, social distance as well. But be safe. Take care. Bye-bye.
Bye, thank you.